Hello everyone, I am Dr. Prithviraj, orthopedic surgeon at Nexus Day Surgery Center, Mumbai. Today, we have a very well renowned faculty in orthopedics, not just in Mumbai, but internationally acclaimed orthopedic surgeon, none other than Dr. Nagraj Shetty. Dr. Nagraj Shetty is an expert arthroscopic surgeon and a sports injury specialist. It's an honor to have you over here, sir. Today, we are going to discuss about a topic which is most commonly seen not only in sports person but anyone of us can experience it while performing our day-to-day activities. That is shoulder instability. Today, Dr. Nagraj Shetty will shed some light over the shoulders instability and also on India's first newly emerged day surgery center, that is Nexus Day Surgery Center. Dr. Shetty, over to you, sir.
Hello everyone, I am Dr. Nagraj Shetty. I am a consultant arthroscopy, complex knee preservation and shoulder surgeon practicing in the city of Mumbai with more than 16 years of experience in my chosen subspecialty. I am associated with the top institutions, top hospitals of our city, and today I am at Nexus Day Surgery Center. The purpose of this chat today is to focus on one of the most common disabilities, conditions that patients come to us with, and that is shoulder instability. Regarding Nexus Day Surgery Center, this is a center which is focused on these patients who are suffering from various joint related problems, which can be tackled sometimes only with exercises, bracing. Sometimes they might require support of some injections in various joints, and sometimes they will require surgical procedures. Most of these surgical procedures can be managed on a short stay basis, and that is where this center is equipped with the most advanced instrumentation, advanced operation theatre facilities, advanced sterilization standards, and the state of the art in terms of our scientific acumen and focus towards our patients. Coming back to the discussion on shoulder instability. Now, a few points about the anatomy of the shoulder joint. The shoulder joint is a ball and socket joint, the ball being provided by the humerus and the socket is provided by the scapula bone. So this is the only joint in the body that allows 360-degree movement, and that is the reason why you are able to bowl, you are able to throw, you are able to perform various dance maneuvers. So this is the only joint which has been given so much mobility by the nature. Unfortunately, because of this high mobility, it is prone for instability. The best way to understand this is imagine the shoulder as a golf ball on a tee. So the tee is very small, that is your socket, and the ball is very big, so that's your humeral head. So the shoulder is prone for instability episodes because the restraints which hold back, like the bony socket, is very smaller in size, and the ligament sometimes cannot manage the excessive stress that is being placed on it. So that is a simple way to understand the anatomy and the predisposition of the shoulder to instability. So basically, instability is a broad spectrum. So whenever there is loss of contact between the ball and socket, it is when we call as the patient is suffering from instability. On the highest end of the spectrum, you've got dislocation, which all of you are aware, where the ball slips out of the socket completely and needs to be put back. That's the most severe form. But in the milder form of the spectrum, you have just the patient experiencing a painful episode or recurrent pain episodes when they get their arm into an extreme abduction movement. In the middle part of the spectrum, you have a entity called as subluxation, where the ball and the socket transiently slip out and come back into place. The patient just experiences some sound, some pop in the shoulder. Another presentation is a different patient who is comfortable in the extremes of motion, wherein the ball and socket slip out, but the patient is very comfortable. That's a completely different entity. Today, let's focus on the traumatic shoulder instability, which we just discussed, wherein the patient can have only pain or subluxations, pops, clicks from the shoulder, or formal dislocation episodes. Now, we need to understand that once the patient has had a dislocation, there is quite a high chance that this can happen on a repeated basis, And when it happens on a repeated basis, we call it as a recurrent instability. These are the patients who almost always require some sort of a surgery, a minimally invasive surgery called as a stabilization surgery. So you are making the shoulder stable back again. So we are going to discuss what are the various options which we have and how we as surgeons are at the forefront in terms of our scientific acumen to get these patients, irrespective of their physical demand, into full action and back to their quality of life is what we are going to discuss ahead. So as we were discussing about the various surgical options for a patient with recurrent dislocation of the shoulder, the first thing that we most commonly do is what we call as an arthroscopic, anatomical, soft tissue, labral and soft tissue repair. So in this, traditionally it has been called as a Bankart repair, which basically involves the cushion in the front of your socket, which is stone and is responsible for recurrent dislocations. This cushion works like a speed breaker, and the idea of repairing is to restore the speed breaker for the ball to be supported and not slip out. This is probably one of the common surgeries which we do. Other than that, in some patients, they do not just have a soft tissue problem, that means not just the speed breaker, but also the road underneath is now weak, or it has got like a pothole, and therefore the car just slips out easily into the pothole. So these are the patients who've got a bone loss, and these are the patients whom we actually evaluate and we decide whether they require a bony procedure, which could be a bone block procedure or a procedure called as a Latarjet, which we are able to do arthroscopically and with a minimally invasive techniques. So these are the various spectrum of surgeries which are available to make sure that the patients with recurrent dislocation are back to fitness and back to their original sports with full force and vigor. Thank you.
Sure, that's great, sir. But as we were discussing before, sir, you were talking something about anatomical labral repair. Can you please shed some light over it for our viewers?
Yeah, so I like to call the soft tissue labral repair procedure as an anatomical repair rather than only a Bankart repair, because more often than not, by the time patients present to us, the traditional Bankart lesion, which is usually the front of the shoulder, has extended into the lower portion of the socket and the behind or the posterior portion of the socket, and the tear has extended all through and through. So we'll end up doing a anatomical labral repair all around the socket sometimes. Sometimes these patients also have rents or holes in their capsule. So the capsule is the covering of the shoulder. Because of the repeated dislocations or instability episodes, they have got rents. In some scenarios, they have got a complete tear of this capsule labral tissue, what is called as a Hagel lesion or a reverse Hagel lesion. They also have Hill-Sachs lesion, which is a defect on the shoulder ball at the behind portion, which we fill up with the capsule and the posterior muscle by a procedure called as remplissage. Sometimes they also have a tear extending into the superior portion of the socket and the superior labrum, where the biceps comes in joints, called as a slap lesion. So that also needs to be repaired. So we need to do a global assessment of the entire labrum and the soft tissue structures and do an anatomical repair of all these labral, soft tissue and bony lesions.
Okay. So, doctor, can you tell us something more about the latest technology or recent scientific advancement in this field of soft tissue repair, specifically in arthroscopic shoulder surgeries?
Yes, so we are relying on anchors, which are basically small stitches which are placed onto the glenoid socket and have got threads which is wound around the toned tissue, and it is tied down to create the bumper or the speed breaker effect. So until now we had the technology called as the knotted anchors, which is still present. We also have the technology which is called as a knotless technology, and the advantage of the knotless technology is that you can create a graded tensionable device in a very low profile manner, which helps in the sequential tensioning in a particular direction and restore not just the speed breaker effect but a very nice tension back in the shoulder, because as you know, because of recurrent dislocation, these patients have lost the normal tension of their capsule. So as for the general audience, what I want them to know is that when you do these repairs, you need to create the anatomy back, not just in terms of its structure, but also its function. So the knotless technology, in addition to the knotted technology, we use in particular sequential manner to restore both the structure and function of the soft tissue structures of the shoulder.
Thank you so much, sir. This has actually helped for young orthopedic surgeons like me to clear our confusion and have a clear point of view. Plus, it will also help our viewer to know and understand about the shoulder joint in detail and in much clear way. I would further like to move ahead and ask you a question on bone loss in shoulder surgeries.
Right. So when we talk about the bone loss in shoulder, we need to understand that it is usually more often than not bipolar bone loss. So there is bone loss on the glenoid, that is the socket side. There is also bone loss on the humerus, that is the ball side. And we need to assess and quantify exactly in percentages as to how much is the amount of bone loss. Let's talk about the glenoid side first. So typically we get a CT scan and we do a subtraction of the humeral head and look at the glenoid socket on face, meaning we look at it end on. And by a particular calculation, we measure in percentages as to how much is the amount of bone loss. As per scientific consensus today, we call critical bone loss anything above 20%, somewhere between 12-15% up to about 18% we call it as a subcritical bone loss, and anything less than 10% is called as a minimal bone loss scenario. So this is on the glenoid socket side. So the second part of the bipolar bone loss is on the humerus side. So on the humeral side, we basically quantify the bone loss as an on track and an off track lesion and accordingly do the treatment for the same. So that was the understanding of the bone loss.
Sure. By now, I guess it's pretty much clear for all of us about the soft tissue injuries and its management. Moving much more detail into bone loss, I would like to ask you, doctor, about the subcritical and critical bone loss and how we can tackle it.
So critical bone loss category is very clear. So anything bone loss which is beyond 20%, it goes into the solution for by a procedure called as a Latarjet procedure. In the Latarjet procedure, we use the coracoid bone which is in the front of the shoulder and we osteotomize it from its position and take it across and fix it onto the front of our shoulder with the help of special implants like screws or buttons. And now we also have a implantless design, which is basically a tape. So it's an implantless device which basically tensions the entire bone into the anterior socket of the patient. So to summarize, for patients who have a critical bone loss, you do a procedure called as a Latarjet. Latarjet basically is a transfer of the coracoid bone, which is in the front of the shoulder, into the area where there is bone loss, that is the anterior glenoid neck. It is fixed with the help of either screws, buttons, or with an implantless tape-like design. Coming to the subcritical bone loss. So in the scientific discussions and in the scientific research that we are performing, we are trying to understand what is the right way to approach the patients with subcritical bone loss. So in my treatment algorithm, I treat these patients based on their physical demand, based on their functional demand. So if I have a kabaddi player with a subcritical bone loss, I would either do a Latarjet procedure or I also have the option of doing a bone block procedure wherein we take the bone graft from the patient's own body. We put the graft in the front of the shoulder and we also do a soft tissue labral repair on top of this bone graft. So the patient gets the best of both the worlds, meaning he gets the soft tissue repair and the tension, and he gets the bone to compensate for the bone loss. So this in my experience covers the entire spectrum of procedures available to us, which we titrate as per the patient's physical demand, functional demand, amount of bone loss and the other findings.
Thank you so much, sir, for this detailed explanation. Moving ahead, I would like to understand more about glenoid fractures and bony Bankard's lesion. Can you please tell our viewers about it?
Bony Bankard basically means that the tissue in front which has got damage, that is the labrum, is not just soft tissue, but it has also got a chunk of bone that has got detached. So this is not a very uncommon scenario. We see this in more than 30% of our patients. These patients might have varying amounts of bone associated with this detachment. It could be a small size lesion, moderate size lesion, large size lesion. Now, typically these have to be repaired back, because when they are moderate and large size, they will land up with, the patients will land up with severe instability. So let us say it is detected in the very first instance and it is displaced, then these patients need to be addressed with the surgery initially itself after the first dislocation. So we do what is called as a bony Bankart repair. We've got various techniques, but what we rely on is the suture anchor technique more often than not, wherein we do a double row, double pulley technique to restore the entire bone back to its place. So these patients in fact do extremely well, because bone to bone healing is there in addition to the soft tissue healing. So this covers about bony Bankart, and the understanding that typically soft tissue repairs are reserved for recurrent dislocation, but if there is a large or a moderate bony Bankart with the displacement, we do these repairs even after the first dislocation. Coming to glenoid fractures. So the terminology is different, but the concept is the same, that the entire anterior glenoid is broken. This sometimes we see as large fractures, and obviously these patients are extremely unstable. What I want to point out here is that you need to fix these fractures back. Do not treat them like bone loss scenarios. Do not do the bone loss surgeries which we do for recurrent dislocation for these patients who have a glenoid fracture. So you need to be having your skill sets to treat them arthroscopically, either with anchors or with screw fixation, or with mini open techniques, where again you need to combine these procedures of using anchors and screw fixations to restore these complex glenoid fractures.
Thank you so much, doctor, for giving us your precious time. This talk show has helped our viewers and will help beginners and budding orthopedic surgeons like me by leaps and bounds. Thank you for being here, sir.